Good morning, everyone. I figure sometimes if you hear a voice, it helps you know we're getting ready to get started. Good morning. Yeah, please make yourself comfortable. We do have some refreshments up here if you need to grab a drink. And I'm Kathleen Hewitt. I just wanted to briefly introduce myself and welcome all of you. Welcome our sponsors for our new program that we're going to be talking about today, AstraZeneca, as well as all of the many ACC staff and all of the other organizations that are represented here today. It's my pleasure for us to get started and introduce Shal, who is our new CEO. So we're excited to have him on board. And I think this is probably your first ACC big project kickoff. Within, at least I think, it's the most important one, if you didn't know that. So thanks for being here today, Shal.
Yeah, exactly, no pressure. Okay. This is, I think we're 10 days into my tenure. How's it going so far? Well, I'd like to, again, echo the sentiments. Welcome everyone to Heart House. It's a pleasure to have everyone here. So many friends here to celebrate this great event, and we have a lot of people who are going to be talking about this. The ACC is a premier cardiovascular organization, member society in the U.S., and we have people who are staff and members who are dedicated to the mission, and the mission being the transformation of cardiovascular care and improving heart health. And this project that we have with AstraZeneca is a testament to that, and the testament to the passion for the mission and a passion for the things we do best. We're thrilled to have AstraZeneca as a partner in this endeavor, because it is truly an ambitious project. It's ambitious, and it's very insightful and forward-looking. It's very futuristic in terms of what we want to accomplish, which is so close to our heart and we're very passionate about. It's a testament to the commitment of AstraZeneca to take this on and be able to do something like this for patients, for patient outcomes, and we're thrilled to be part of that. And I think it's going to be and will be an example of a true partnership, and a partnership that benefits patients, benefits outcomes, and certainly is will be a big part of the community and the value add to the community. So without further ado, I want to introduce Dr. John Harold, who is the president of the ACC. John?
Well, good morning, everyone. I just want to welcome all of you to Heart House, which is our home away from home for the 43,000 cardiovascular professionals who represent the ACC. We represent cardiologists, we represent the entire cardiac care team, nurses, pharmacists, and so on. And we're delighted to announce this new partnership with AstraZeneca, which will make a difference in our patient-centered care approach to the nation, and as part of the Navigator program to reduce this issue of readmissions, which you'll hear a lot more about. But again, I want to say that over the last several years, we've moved to this mission of patient-centered care. We have many participants in the audience who played a central role in that mission, and I think this particular project is the culmination of many of these efforts to really translate a vision into a reality, into our healthcare system, to really focus on patients, focus on acute coronary syndromes, what happens at the time of discharge, what happens after discharge, and how we can make a difference. And we want to thank AstraZeneca in particular for their vision, for their support of this particular program. We look forward to a long partnership and a long collaborative relationship. And I want to introduce now Harlan Andrew.
Thank you very much. I can't tell you how pleased I am to be here with you. There are some problems that are so formidable that they really do require us to come together as a community to try to help solve. The idea that we can bring together the expertise and energy and interest of the American College of Cardiology with the creativity, support, and vision of AstraZeneca and others, in the sense that this isn't intended for it just to be us, but this is about getting this started and trying to pull in others, is an inspiration to me. I want to talk to you a little bit about readmission, but I just at least wanted to pause and say that I really think this is a bit of a historic kind of event. We're not here to promote a particular product on either side. We're not here to try to enrich either side. What we're trying to do is to have a vision about what society and patients need and try to figure out how we can work together, recognizing our own responsibilities to our organizations and our members and our constituencies, but feeling that if we can be successful, then we will all have our organizations benefit, but more than that, society and patients will benefit, and it will be fully aligned with our mission, and we'll be able to demonstrate the ability to work together, to find common ground, to show that we can bring different groups together, ideas, different even cultures to some extent, and we can find common ground where we can work really strongly together. And no one's going to be able to look at this agreement, no one's going to be able to look at this collaboration and see anything but a commitment to patients and society. And this will, I think, strike a chord with many people who wonder whether or not industry and academia and clinicians can work together for common good. I mean, let's just be honest. There are many people who are questioning that ability in trying to get actually people to stand in different areas. I myself have been one who questioned some of the practices that have occurred. But I want to be very clear. It's about practices that are not in the best interest of society, that don't always push the best interests of patients. And when I was told about this and I understood what had been put together, I said, let's show as an example how we can work together, how we can adhere to the highest principles of our professions, and how we can show that we can do the right thing together. And this is a perfect problem to bring us together, to work on together, because it's complex, it's difficult, it requires new and creative, innovative thinking. If I'm involved and as ACC is involved, we need to send a message to AstraZeneca. This is not just about your money. This is about recognizing the skill and deep expertise that resides within your company and wanting to tap that with the expertise that exists here and elsewhere to find good ideas wherever they may stand and bring them together to solve some of the issues that face us. And so this is and ought to be a true partnership where we're working together, we welcome others, and we are dedicated to trying to make progress. Certainly the financial resources are critical. The capital helps us to be able to do things we wouldn't be able to do otherwise. We have programs in place that are making some progress but are undercapitalized, that can't really achieve the entire promise of what they've been able to set out to do. This will help, but it is only going to really achieve its full promise if we find ways to truly work together and welcome others and do it in a spirit of, again, trying to accomplish what's good, work together. So for that reason, I'm very excited that this initiative has begun and appreciative that you've turned to the cardiovascular space and the foundation that exists here to see whether or not we can go forward. Now people can hear me. I'm going to start over. Okay, so I just want to do a kind of a quick briefing about at least a vision of readmission as it has emerged and what we might be able to do together and the problems that we've got in front of us. And I just want to break this down into three areas: the patient, the problem, and the path. And the path is, what are we going to do forward? How are we going to go forward on this? So first and foremost, we have to understand this issue that we're facing from the patient perspective. I believe that of all the things we talk about these days, about the things that we need to fix in medicine, this is the ultimately patient-centered problem. And if we're successful in talking about readmission, we are going to flip the usual construct of taking this from the point of view of clinicians or the healthcare systems to what is it like to be a patient. Because the whole reason I believe that we've got this readmission problem is because, as we're taught as doctors, it's about in silos. They're in the hospital, they're hospitalized patients, and we have to get them out of the hospital. And we are outpatient physicians, we see them come to us, and now they're outpatients. They were inpatients, now they're outpatients. And we may bemoan the lack of information that we got, or even that we were notified that they were in the hospital, or we had the opportunity to contribute. But we don't even realize when we were inpatient doctors, we were the ones that were doing that. You know, we have segmented it according to our convenience, but that's not how patients see it. It's an episode of care for them. It is an episode of an illness that may go on for a long time. Thinking about readmissions is all of a sudden thinking about what is it like through the patient's eyes. How is their experience? They're not experiencing, I'm an inpatient, I'm an outpatient, I'm a person. And this is, my care is stretching across venues It's not that I'm labeled as one or the other, and this is what has to, I think, change. And when they're leaving the hospital, often we're putting them in a position where they're walking a tight wire, trying to get from the one venue, the inpatient, to the outpatient, and it's no wonder that we identify so many problems that occur in this area. And our job is to get them off this tight wire and help them make a very safe passage and lower their risk as much as possible. And this idea of the revolving door has, I believe, can be addressed, and we can make it safer for them if we begin to look through their eyes, if we begin to try to understand what is it like to be a patient and what they're experiencing and the kind of things that we're doing that may be conspiring against that. When I think about this issue, we have, when people are leaving the hospital, about 1 in 5 who are ending up back and being readmitted only within 30 days. And for some reason, we've never gotten it through our heads how high a risk that is. I cannot find anywhere another group of people in any city, in any country, where in the next 30 days, 1 in 5 of them will end up being hospitalized. And I want to even get rid of the word readmission, by the way. These are catastrophic health events that occur to people that are so threatening to their health that they have to be readmitted to the hospital. There are not a lot of people who have been in the hospital who look forward to going back into the hospital. It's not a repeat performance that most people desire to have. The hospital isn't that much fun that people are dying to get back in. And so for people to be that sick that they have to be re-hospitalized again is a major big deal. And I feel we almost sanitize it, by calling it readmissions. It's just a readmission, they were readmitted. The kind of ripple effects this has on people's lives, the threats that it imposes on them, the difficulties that occur as a result are quite large, and we need to acknowledge that. And so when we're thinking about the large numbers of people, we need to also be thinking about how do we lower that risk. I want to move away, by the way, from the idea of a preventable readmission. I believe that almost all the readmissions have a degree of preventability. There certainly are some at the end that are the direct result of an error, and there's some that are truly an random act in the universe. But in the middle, the vast majority of these are about risk. It's in the same way that you would want to reduce the risk of an acute myocardial infarction or acute coronary syndrome. You can't necessarily say which one is preventable, but if we take a population and treat them well, we can reduce the risk. There will be fewer events. We need to be thinking about that issue. So the patient is the most important perspective we need to have about this, that this is truly about a patient-centered approach. But I think we need to really understand the problem, too. And it's not as simple, I think, as it first seems. Certainly, the complexities involve the idea that there's a patient that is within a hospital, at least at first, within a community. There are a lot of factors that will affect whether someone is going to be at risk of readmission. And in fact, the severity of their disease doesn't predict well who's going to be readmitted. This is an interesting insight. You can take all of the risk predictors, what their blood pressure was when they came in, what happened to them, whether all the kind of what their renal function is. And those things are weak predictors of who's being readmitted. And I think it's because the things that happen afterwards are often different than what happened in the hospital. And the degree to which the quality of the healthcare system and the way in which it's able to help people bridge from inpatient to outpatient are things we're not putting in the risk equation, but end up being very important as to whether people can be successful in their recovery. Another thing is I published this commentary piece in the New England Journal where I start calling this post-hospital syndrome, an acquired transient condition of generalized risk. What we began to notice was that among people admitted to the hospital, the reasons that they are readmitted are most often not the reason they were initially admitted. It's only a minority of those cases. So even for heart failure, which ends up to be the most, only about little more than a third of the patients come back in with a heart failure readmission. And ACS, which I don't have up there, it's even much smaller that they're coming in for another ACS event. And it turns out that the causes of readmissions span the entire spectrum of a medical textbook. They're at risk for a whole wide variety of things. And it got me thinking that what's really happening is, for a discrete period of time, they are impaired. I think they're immunosuppressed. I think they're cognitively impaired. I think their metabolic systems don't work well. Their cardiovascular systems don't work well. They are at elevated risk for a whole range of different things. And the degree to which we only focus on the one problem they came in with, I think, is the degree to which we're going to fail to truly make progress and help them have a successful recovery. I just wanted to show you a series of these figures that we're putting together. We're trying to understand this in terms of risk trajectories. And this is days after discharge down here on the x-axis. And this is the risk of being readmitted after going home from the hospital. And this is going to show you readmission and death. And this is what the risk curve looks like from the moment you go home. So the first day, most people make it through the first day they get home. It's only half a day usually for most people. So, but then you can see this is where the risk goes. You're high immediately, and then it starts to tail off. This is what mortality looks like. It's still high and starts to tail off. This is heart failure. If you look at how long does it take you for the risk to decline by 50%, I've now changed the x-axis. It only goes out to 2 months now. You can see that for heart failure, the risk of death declines 50% by about the 12th day. But for readmission, you're out at day 43 for the risk to decline by half. Similarly, for myocardial infarction, it's shorter. The risk of readmission declines by half by day 13, death by day 6. I think this is how we're going to have to start thinking about this. What is the actual period of elevated risk that patients are experiencing? How long does that period last? What are they at risk for? And then we can hone our interventions to those periods of elevated risk that we're trying to get them to climb. We want this curve to decline faster. And you can see out here, finally, people start leveling out to whatever their baseline levels of risk are. But it's in that early period that they experience it. And again, when I get to this period of this transient risk, acquired transient period of generalized risk, I think in part it's the illness they came in with. Their reserves are depleted. It's hard to read this, but in the hospital, people are sleep deprived, they're malnourished, they have pain and discomfort, there's medication overuse, underuse, and misuse, deconditioning, mental and physical stress, and other stressors. I think in the cumulative effect, all of these things on top of the acute illness lead people to this. It's like the worst case of jet lag you've ever had. Since you're AstraZeneca, I know you travel a lot, so you can relate to this. But I mean, for those, if you really have a bad case of jet lag, I mean, people can be talking to you and you just don't hear them. And your ability to learn, listen, perform at your top level is impaired. But I think there are studies of all these things. Sleep deprivation impairs the immune system, impairs the metabolic system, it impairs cognitive functioning. Malnourished, there's a study in JAMA that said that about 20% of the patients in the hospital get less than 50% of their nutritional needs. Sometimes it's us. We're canceling meals for procedures that never happened, so we have to cancel them again the next day because we just didn't get to them. And all these sorts of things are happening to people, and it's being neglected. So you take those things, and they become very important. Other quick problems. In our own institution, we started looking carefully at our ability to execute the transition. Inadvertent discontinuation. This patient, we looked carefully. Heart failure patient, the ACE inhibitor fell off the discharge medication list. We saw this patient. They were being treated with 2 beta blockers. They were being sent home on metoprolol and carvedilol because they came in on metoprolol. They'd been started on carvedilol. And when the person put it together, they're being sent out on both. Follow-up appointments. 2/3 of the patients discharged without a follow-up appointment. When we called people, half of them reported no follow-up appointment within 1 week. This was about a year ago we started doing this assays. But when you started looking, it was just everywhere we were failing to do the very basics. Discharge summaries dictated more than 48 hours after discharge. Many of them weren't, and more by house staff. 38% were not sent to any physician. 56% not sent to at least one of the follow-up MDs. Nursing agencies weren't getting them at all. Part of this is a vestige of the way we were taught again. As trainees, we were taught, get people out of the hospital, and it was almost a badge of honor how long your discharge summary list was before the chief of service would send you a note and say, you're going to be suspended. And you knew they'd never suspend an intern because we were the cheapest labor, and it was always a false threat. But We were never taught that actually we were doing a disservice to the patients, that this actually was a critical piece of care. And if we cared about them and examined them carefully and getting them on the right course of treatment when they first came in the hospital, this was just as important. But not one person ever told me that. This was taught to us as being something bureaucratic. The idea of coordination and collaboration and communication was not on the radar to any extent at all. When we looked at the content of our discharge summaries, we tell everyone a lot about what patients are like when they come in the hospital. We tell them almost nothing about what they were like when they went home. So when you show up in the office, you have everything about what the patient had that led to the hospitalization. But when you're saying, gee, I'm examining you and I'm noticing something, I wonder if it was like that when you went home, you can't find it. So these are all things that, some people are commenting upon this. Grace James at our place, and Mary Tonetti, they wrote The Journey Across the Healthcare Discontinuum for Vulnerable Patients. This is our challenge. This is our opportunity. With this investment, with the team that exists in this room, we have the possibility of thinking differently about this. I just wanted to share with you some quotes that also came out of the institution that also show you the level of dysfunction in the work that we've got to do. Are doctors seeing this just through their own eyes? This is what people are saying. Sometimes appointments have to be coordinated. Prescriptions have to be sorted out. Med lists have to be reconciled. And that can't all happen before 11 o'clock. Since we're rounding for a lot of that time, it's more important to get the patient out than it is to be thorough at discharge, is how it feels a lot of the time. There's two things in here. One, this doctor's saying, with the current workflow, I can't do what I'm supposed to do. I got to get him out. Second of all, this doctor's reflecting on what it feels like for them. God, I mean, you hear in the voice, wow, this is impossible. I'm stressed. Instead of saying, we're endangering patients. Here, this one says, it's stressful to be discharging patients on the days you're admitting. The doctor, I'm stressed. It's hard to balance to get those new patients tucked in, getting all their information, etc., because it takes a good hour to discharge someone. We've got a problem if these are our trainees. All we can think about is like, this is a pain in the butt for me, to try to make this happen, instead of this is a critical part of taking good care of patients. I'm almost done. You're post-call, the hospital administrator wants you to be out by 12, but they're also saying do all the stuff, so which one do you want me to do? And there's so many other people involved. This is an inpatient. I often don't know what's going on. Is the care coordinator arranging a short-term rehab spot? Anyway, it's all, you can see what's happening, and I don't think that we're an outlier with regard to the issues that we're facing. So the path, finally, I just want to say that we need to fix the easy stuff. This is a picture of a boat with holes in it, but people are trying to get the water out of it as fast as they can. This, to me, is like a perfect metaphor for some of the work that's going on right now. God bless the people who are trying to empty the boat with their buckets. But if we don't fix the holes, we're never going to make any progress. And just putting more people in the boat to be getting the water out isn't going to be the way. So we've got to figure out how we challenge the hospitals, our colleagues, our healthcare environment to fix the little stuff that actually in cumulative ends up to be big stuff. And then I did take this Apple thing because my theme is think differently. If we do this and we aren't transformational, if we do this and we just add to the status quo and the way people are approaching the problem, then we have not in any way fulfilled the promise of this project, and we have betrayed the investment in it. We have to be thinking, what's new? What's different? How is this problem going to be solved with different ways of thinking? And the challenge here is going to be to try to bring together talent and to think not about readmission, but successful recovery. And what does it mean to reduce risk? What does it mean to help people to be successful and safe? We need to mitigate the toxicity of the hospitalization, and we need to promote the safe transition through this transient period of risk, and ultimately focus our eyes on how we're going to help individual patients throughout this country and the world. Thank you.
I just want to introduce Paul Hudson, who's the Executive Vice President for North America AstraZeneca, to give us the reasons behind the program and give us some additional background. And thank you, Harlan, for a wonderful discussion.
Thank you very much. And wow, that was truly inspiring, I have to say. You don't realize just how big the gap is, what the evidence already is, and what can and can't be done. I think it's also important, just by way of an introduction, to say that I'm very privileged and humbled to be here and supporting this program. I've been with the company in the US for the last 5 months. Before that, I was leading AstraZeneca in Japan, and I've been commuting for the last 5 months. So I apologize in advance for the jet-lagged, apparently sleeping meetings that I've been doing since January. So thank you for putting that out to everybody. So we as a company feel every day that we're proud to put the patient at the center of absolutely everything that we do. We feel it, we're in meetings. You'd be amazed if you don't work. I know Shal can probably talk about this, but if you don't work in our industry, you assume that we're spending all our time talking about how to conquer the world and have high market shares and do these things. You'd be amazed about the time, which is probably the majority of it we spend talking about patients and trying to do good. It's not often, though, that you get to be involved in something that is actually able to demonstrate that commitment and to share with people that we're proud, tangibly, to put something back. Now, I don't share a lot of personal things, but I was at a wedding in London last weekend, and I was with my wife, who's one of 6 children, and there are 16 grandchildren. And she lost her mother very young through a heart attack, and she's never met any of those grandchildren. So my wife asked me, what are you doing next week? Because she's still in Japan. We're commuting. It's a long-distance relationship. I said, you know what I'm doing? I'm going to the Heart House, and I'm going to do something really interesting. We're going to invest in something really cool that is about patients. And she says, how great is that? And I said, well, you know, the truth is, I don't know how good it's going to be. I've heard what people have said. It was a program that was initiated before I was here, and I'm just coming up to take the credit for it. So, and there's a component of that. There is a component of that. But you know what? I hear that, and I hear from what my team say in and around the business, and I know we're doing the right thing. And as I said to Charlotte, I hope it is the beginning of something and not the end. We know from our work in areas like ACS, for example, we know that people are so happy to be discharged, whether it's by 11 a.m. or with or without the correct meds. We know that people are happy to go. We know that they're feeling so much better. And we know that perhaps it's not the best time to listen to the information that you're being given or to understand what it's going to take to be healthy and not to be readmitted or have another catastrophic medical event. We know that and we see that. And we don't know how to do something about it, and you do. And you have the credibility, you have the expertise, and you have, quite frankly, the opportunity. We're delighted to support the program. I hope it's the beginning of something much, much bigger. I'm proud of the people that made the decision to be involved in this program. You know who you are. And I really hope that we can give something back and we can really demonstrate that we genuinely put the patient at the center of everything that we do. Thank you very much.
We have some panelists, if you wouldn't mind coming up. And do you want to present? You have slides you want to present? Yeah, okay. Maybe we'll just go through, have everyone just introduce themselves. And then, Minnow, you have a few slides you want to present. And
So I'm Minnow Walsh, and I am a heart failure cardiologist from Indianapolis, and at the ACC, in addition, work with Harlan on our Hospital at Home initiative, and also I chair the Patient-Centered Care Committee, which shows you that the ACC a few years ago realized the importance of putting the patient at the center of everything we do.
Oh, hi. My name's Andrew Smith. I live in Orange, Connecticut. I'm a member of Project Access. And did you want me to now? Or? Okay. But yeah. Yeah, I'm here to speak for the patients. I noticed earlier this year when I was on a job that I was starting to get winded, and this was just from walking, not doing anything very strenuous, and I just I was just I'm a little nervous, sorry, but then I went to see my sister's doctor, and he right away he did an EKG, and it was it came up that I had AFib. And so he put me on metoprolol, and I had a high blood pressure as well. And so I had decided to, he recommended Project Access. And he said, go online and see what they can do. And I found out that I had to be recommended by a doctor. So they sent him the forms, and he spoke on my behalf and they accepted me. They called me back, said had to go in for an interview, and they, when I spoke to Giselle, one of the navigators from Project Access, she said I was eligible. And anyway, so she referred me to a Dr. Forrest, a cardiologist through Yale, and he came. I had an initial exam, and he found out they wanted to do an EKG. They doubled my metoprolol, and I went to see him 2 weeks later, and he said that I was doing better. My blood pressure was right on. It was 114/70, so that was back to normal. And then the echocardiogram came back much better than the first one I had taken when I was with Dr. Gimbel, my other primary care doctor. Anyway, he always wanted to see me for 6 more months, and he said, I'm doing much better, and just to maintain, he doubled my metoprolol medication, so that, that's what got me to the point where I am now. So, I mean, I can't say enough for Project Access, because financially they really helped me out.
Let me just, first, Andrew, that's great, and you're not used to speaking in front of a...
I've never spoken in front of an audience, I'm sorry.
So this is sort of...
It was so tough to get started. I know you all make it look so easy.
No. This is actually just a stress test Dr. Forrest asked me to...
Right. Well,
to see whether...
I don't want to have my blood pressure checked right now.
I'm just thinking, I hope he doesn't go into AFib with us.
Exactly. Oh, God.
No.
There's so much more that I wanted to say to get really more...
Well, we're going to go through the panel, but just so everyone knows that Project Access is a program at Yale that helps with navigators for people who are having trouble getting access to specialists in particular. And Andrew was kind enough to say that he would come down, but just you being here with us is so important. And I can tell you, man, it's just moving to hear you talk about your experience and the challenges that you face. So,
yeah, I mean, I was worried because I put it off as long as I could. I didn't have regular insurance, and the first doctor I went to see that my sister works with told me that it could get expensive, as far as the heart goes and everything. And so, that's when he recommended Project Access. And when I looked online, it said right off the bat that I had to be referred to. And when he spoke to them, Giselle had called me back saying, clinically you're already accepted, but you have to come in for an interview. I had bring my W-2s. It was almost like a state type thing. And once she saw what I had made last year, unfortunately, but she said that I was eligible because I didn't quite.
The doctors have agreed to see patients without insurance, and the navigators help get them to the right doctors.
Yeah, right. She navigated me through. They referred me to the Dr. Forrest, the Yale cardiologist, and his group. Very nice doctor and his group. And when they took my vitals the first time, it was okay. But I had seen him 2 weeks later for the echocardiogram, and he said compared to the first echo I had done with the other doctor, he said I wasn't firing all cylinders. He was worried, and then he once they saw. The second week, and when I went in for my blood pressure, like I said, it was 114/70, which was perfect, compared to what it was. And the EKG, the echocardiogram said, yeah, it was much better. So as long as I stayed on my meds, I'm doing okay. And they leveled me off with the Coumadin as well. So I'm trying to get it going once a month, but right now it's every 2 weeks. So, and
well, we really appreciate.
Thanks so much. Yeah. Okay.
Hi, I'm Joy Pollard. I am a cardiology nurse practitioner. I come here to DC from Michigan. I am involved with, or was involved, we just finished a year-long pilot project with a hospital collaborative, 12 hospitals in southeastern Michigan, focusing on the hospital-to-home initiative. We used the toolkit from the American College of Cardiology. We had partners, the Greater Detroit Area Health Council, and also MPRO, which is our Michigan Quality Reporting. So I have to say, I am so honored actually to speak after Andrew because he is really the voice of just what we have found through our collaborative, and that is from all age spectrums, people are trying to cope with complex issues. And he brings to us not only his forthrightness about his disease, but he also talks about what's actually personal to him, which is how do I, in my life, in my circumstances, stay healthy. So we're happy for Andrew that he has Yale and their wonderful program, but we would like to see a larger portion of this actually become the norm throughout the country, where there are places for patients to go that can help them navigate through this. So thank you for being here this morning, and I will turn it over to Dr. Walsh.
And I'll just briefly, that's fine, that's fine. My name's Judy Tingly. I'm actually a nurse administrator at Columbia University Medical Center, and I work with a variety of institutions, not only our major academic quaternary care center in New York, but also our affiliate program. So I'm coming to you today to just contribute as a hospital administrator's perspective.
Great. I think, Minnow, you've got some slides, and then we'll just start a general discussion.
Thanks, Harlan. Andrew, you did better than most of our fellows do the first time out.
Yeah.
Rough start.
Yeah.
And I gotta say, Paul, we all know how important a project is if the spouse knows what it is. So, thank you. I just want to show you a little bit of a needs assessment for what our project is today, and I want to show you a little bit of data from our hospital-to-home program and CardioSmart, which is the ACC's patient-centered effort. We interviewed people from the hospital-to-home initiative, and I just want to show you that 96% of people who were involved, these are institutions and caretakers and nurses, doctors, all involved in our hospital-to-home, 96% felt that readmission of patients at their institution was a #1 priority. Our CardioServe panel is a bunch of ACC members that represents our membership, and they too find this to be a top priority. But what are the challenges in implementing a focus on readmission? And this is real data, talking to real doctors and nurses who work in the field. #1 among them, lack of staff resources. Difficulties with workflow, Harlan already talked about that. Competing priorities and no funding were the other top ones. So CardioSmart is our patient initiation effort to try to draw our patients into our membership through a web portal and other activities. And I wanted to show you a little bit of data that we've looked at from the CardioSmart standpoint. We went out in an exploratory fashion. We did some qualitative research. What I'm going to show you is a little bit of quantitative research, predominantly cardiologists and patients, and we surveyed them late last year. I wanted to use this slide and put it up for quite a long time because I want you to look at the discrepancy between what doctors think, what cardiologists think, and what the patients think. If you look at the 47-point gap between patients thinking that they care for themselves well with this disease versus what the doctors think, huge gap. So our patients believe they're doing well, but we know with issues regarding medication adherence, other issues, diet, etc., that there's a big gap in what the patients can do and are doing. And most of the challenges that both the clinicians and the patients saw had to do with self-care. Weight, medication costs, medication adherence, whether or not they could exercise, whether or not they were on the right diet. But in the light blue is the clinicians, in the dark blue is the patients. So in every step, the clinicians feel that the patients have a bigger gap than the patients actually realize. So that's an important point about this initiative. Insurance coverage, lack of awareness, limited office time, and lack of alternatives are other issues. There is a critical need for patient education. This is understood by the clinicians, that patient education is the cornerstone to success with regard to readmission. And there are many different desired tools that can help with medication adherence and self-care. And this is the last data slide. I wanted to show you that although we as physicians and clinicians think that we're providing education, the light bars are the clinicians absolutely certain that they're providing education to their patients. In the blue bar is what the patients think they're getting. So there's a big disconnect there between patients and clinicians. So as Harlan outlined, readmissions for cardiovascular patients are frequent for many reasons. Hospitals and clinicians want to decrease readmissions, but the challenges remain. Patients really do think that they're taking good care of themselves, but could be helped. We need education. Cardiologists know there's a need for education and want more help with that, and we need to look at innovative solutions to these gaps. And I will stop.
So I wanted to give the panel a chance to even expand upon what they think are the most important issues that we ought to do, and what are the perhaps the primary innovations or approaches that ought to be taken. So Judy, I want to just start with you, and we can just go down the line again and maybe foster a conversation.
Well, first and foremost, I think the biggest thing that I can reiterate, and it's probably already been stated and restated, but it is the enormity of this challenge. There is definitely not, there are some common themes to what we can do, but there's not a single one-size-fits-all approach that's going to work across this great nation of ours. The disparities regionally, the socioeconomic status factors, we actually did a fairly in-depth drill down on our patient population and the challenges that we were facing and what window of time were the challenges and who was at highest risk. And being a quaternary care center, we're not only dealing with patients that come to us directly, but we're dealing with patients that have come to us at the end of treatment options in community hospital settings. So the complexity for us is very challenging, and we don't have the solution today. We're still knee-deep in trying to identify what will work best for us. But in reviewing and hearing what's being thought through this program individually, I think the key here to the success of the Navigator is the early intervention and the frequent intervention in that vulnerable time frame. I think that would work on a national perspective. I think if we can review what has been taught from our perspective, again, and with family, and frequently, the potential for success will be greater. And I hope that gives a contribution to the discussion.
Yeah, for me, with the navigating, Giselle, I got to know the people from Project Access pretty well. They're always concerned about when I always make sure that I have to check in, first give them the date of my next appointment, call them back afterwards, tell them how it went. They're always concerned about my health and getting me the right medication and the help I need. Yeah, they've been a great help. That's why I felt the need to come here today, at least and speak on their behalf. So. As far as navigating goes, them getting me referred to Dr. Forrest, like I said, it's really helped out, and as far as financially too, because I was in a bad way there for a while. I couldn't afford the proper medical help I needed. So, really
I think the one thing about that I'm hearing from you too is that sometimes in medicine we're so focused on the medical problem we don't see the whole context that the patient's having to deal with, and
prevented me from going in the first place to get the help I needed.
And so one of the most important things here was seeing you as a whole person who had issues that needed to be overcome, not just the medical problems, but all of them. And I think that's a good reminder. I enjoyed you. Thank you, Andrew.
Actually, Andrew, again, gives me a nice segue. One of the innovations that our collaborative found was that one size does not fit all. We had hospitals that were small community hospitals, some hospitals who had quite a developed heart failure team. Of course, we were focused on heart failure patients, and we used the toolkit that gives you suggestions on how you might achieve the patient seeing a follow-up within 7 days of discharge from the hospital. So our sharing actually found that everybody was facing kind of the same challenge. The first thing they had to find out was what was the barrier to a patient not getting to the appointment within 7 days. So some of those focused on the patient knowing that there was an appointment before they left. Some larger hospitals were able to develop what they called a care coordinator, which sat with the patient and the families There are many patients who are not able to transport themselves, especially if they've been in the hospital. I know one of the recommendations we're thinking about is maybe not having patients drive for a certain period of time. They've been in the hospital for an extended period. Secondary to the fact that some of these readmissions are based on motor vehicle accidents. I mean, there's a lot of things we really don't know yet about the overall impact of being in the hospital. So care coordinators would make the appointments. The other thing that heart failure patients have a lot in common is that there are many comorbidities. So having someone coordinate the care for not only the follow-up with the cardiologist, but also the endocrinologist or whoever else they needed to see would be helpful to the family and the patient. So it's helping success the patient to achieve the goals that they need to have rather than the goals that the hospital or you know, any other entity needs. So how do we do that? So that was one of the innovations that one of the hospital systems were able to put together. Another was a smaller hospital developed a program where the navigator met the patient in the hospital, was introduced to the family, they became aware of who they were. This was actually a nurse, which falls into a role that, you know, we're very familiar with. And then as the innovation was, then they would say, now I'm going to come to your home. And that same person would then make the visit to the home and again go through things like medical reconciliation. But what they did was rather than just do a checkoff, they had the patient take the actual pill, write down what was next to it, tape it to a sheet. I mean, you know, these are things that are actually practical in a home, especially when patients are on multiple medications, not sure what they're there for. It gives the health professional a chance to see, is there an opportunity for education? I know that Andrew's been dealing with Coumadin. We all know from a healthcare standpoint how difficult that is, a drug for us to manage safely with the patients. So in the home setting, they found that this was actually an area where they were more open and relaxed and to have this medical reconciliation and education ongoing. So I don't want to take up the whole time, but there was so many different ways. I think that if Harlan's looking for a bottom line, it is that this is a dynamic process, and I think our biggest success was in collaboration with the hospital systems that they were working in to change from static to a more dynamic process flow of how we need to approach the problem.
Yeah, I think Minnow has something. It just reminds me, too, about how we can make these scalable, generalizable, even as we recognize the diversity, and how we fit it in with our current healthcare system so that the incentives are aligned. There is some incentive now around readmission. Plus, there now is payment for this early transition visit. We need to make sure everyone knows about these things and that we're able to leverage whatever does exist in our healthcare system. I know, Minnow, and then Judy, you were in follow-up?
Yeah, I would just wanted to sort of give an in-the-trenches view of from the clinician standpoint and what the sea change has been with regard to the hospitals being engaged. I think some of the comments that the House staff in preparing the discharge summary and what their workflow is, you know, this is actually a new day in healthcare for us as doctors because we were very siloed in our institutions. We just, you know, admitted the patients. There's only one person who can admit you to the hospital. It's a doctor or a nurse practitioner, right? And we decide when you leave, or you leave against medical advice. So that's the doctor role. The hospital role is to provide clinicians to cover the patients, medications, et cetera, et cetera. But then the big disconnect is afterward. And because the hospital responsibility ended, but the clinician responsibility went on, whether it was the clinician who saw you in the hospital or somebody else, and it was as if the hospital was done. And due partly because of the ACA, but also because of the readmission penalty, the hospitals are now, we all have our arms around the same problem to some extent. And I was saying to some of the people before, this is a joy to me as a heart failure specialist working on this problem for years, that I see a level of integration and hospital interest we've never seen before, ever. We have administrators now, wanting to work on the problem. And so I think this program is very timely because the problem's kind of changed. And as we're going to go as a hospital system at risk for patients, these type of strategies are going to be very important to us. And so this siloing of what, I don't think the house staffs quite see it yet because they don't see the patients in the outpatient setting all the time. They eventually will. And we see that it's from the patient's standpoint, I'm still the same patient. I just, walked, got in my car and went, and I'm still the same patient. And my hospital system shouldn't abandon me. My hospital system should be involved all along the way.
Well, and I think the benefits here too is it is timely, and you're absolutely correct. It is of keen interest right now to hospital administrators to find solutions to these issues, and it is a culture change. It is a complete mindset change from a hospital administrator's perspective, where admissions were the revenue source, where now we're actually looking at penalties for these readmissions. So it is very timely. We're looking for solutions. Hospitals are looking for solutions to address readmission, but also I think what we're offering is not just that. I think we're offering a new way of delivering care, and the hospital administrators really need to be a part of the HEART team. If we're going to care for these patients in a team approach, providing navigation that's patient-centered, they've got to be a part of the solution.
I don't know if anyone in the audience wanted to ask a question or make a comment. You don't need to. Yes, please. All right, here, I'll give you this.
But I really can't resist. My name's Beth Capatio. I work for AstraZeneca, but before I lived this third career, I was a primary care doc, and I can't help but notice that we don't have the recipient of the patients in the community. So I just thought I would say thank you for giving voice to so many things that are on my mind. I'm also a daughter of 2 aging parents with a ton of readmissions. And also, for years, from a primary care doc's perspective, this is what's broken about the healthcare system. So thank you, and on behalf of my still fellow PCPs, yeah, we need to do this.
Can I say something about that? So in our hospital to home initiative, which has been going on now for over a couple years, although the focus is readmission, and was the nidus of the program, we have not only members of our organization, which includes all clinicians, but also many who are not, including primary care physicians. Not a lot of primary care physicians, but a lot of people jumped on board to this learning community, and it's very active both online and listserv, et cetera. And we hear from the primary care community often, but I do think you're right, we should have had somebody up here talking about that.
Was there someone else who wanted to?
Good morning. I'm Bill Otchin. I'm a cardiologist. I'm also Senior Vice President of Science and Quality here at the college. And I just wanted to first of all, thank Andrew for coming. You did a wonderful favor to us to come and give us the perspective that you have. It really is wonderful, and thank you for making the effort. We at the college really appreciate it. The other thing that the other observation that I'd like to point out about this that I think we hinted at a little bit at the beginning, but I would just like to hear Joy and Judy particularly give us a little bit of their perspective on the fact that this is really an extraordinary partnership. And we've talked about hospitals, we've talked about patients, we've talked about cardiologists and residents and fellows, we've talked about primary care physicians. But here we are in a meeting that's been essentially called together by a medical professional society and a pharmaceutical company. And that's kind of an extraordinary partnership that I would like to hear you all reflect on a little bit, if you don't mind.
Again, I think it's a new day in healthcare. I think the delivery system, out of absolute necessity, is shifting its focus from being what it has been to what it can be. And I think that the goal and the intent here is that we're patient-focused. No longer can we make decisions medically or administratively about care without including the patients and really collaborating and working together. The solutions will not be found in one individual subspecialty. It will not be found in one individual administrator or one individual hospital. The solutions will be found when we work together to explore out-of-the-box thinking and engage Andrew and his cohort as part of the discussion and dialogue.
Joy.
Thank you for the opportunity. I think that's a great question. One of the benefits that I can see right from the beginning is the fact that there will be more people involved. Frankly, we can't do it on our own. So from a nursing perspective, we have always tried to put the patient's autonomy as the focus. And that's certainly something here at the college that has always drawn me to be a member of the American College of Cardiology, is the idea that if you have the patient at the focus, you need a team. Team is not a word that is foreign to the American College of Cardiology, and I'm proud to be part of that team. So from that perspective, I think that this is very synergistic with the whole concept that we have made a large effort to build. So we know that team members are also going to include pharmacists and PharmDs. They are already in their own profession taking an active role in education, changing so that they have a more visible presence both on the hospital floors as well as part of the team. In addition, there are case managers that have always worked in this area. There's social work, there's financial obligations, there's navigating through a system that is going to be changing for all of us. We're going to need help navigating. So we're going to be looking to our hospital partners to find out what is the best way to help the patient, what is the best way to accomplish something without duplication. So the idea of having a navigator to be able to streamline and help all of us is something that I'm looking forward to.
Okay, I wanted to just, do you want to say
Yeah, I
something?
just wanted to say thanks to Shilpa for inviting me here to speak on behalf of Project Access, and sorry I got off to such a rough start, but yeah, like I said, I hadn't spoken before, but I really appreciate what Project Access has done for me, and I don't know where I'd be if I wasn't involved in the program.
Thanks, Andrew. So I wanted to ask Joy, Judy, and Minnow one quick thing, so I won't put you on the spot for this, but you're welcome to if you want. So this is lightning round. Quick, if we're successful, what's the world look like in 3 years as a result of this project? What's the headline? What's the world like? Lightning round.
So in 3 years, I think knowledge dissemination from this project to our larger community outside of cardiovascular specialists to primary care. So with this being an explored and then a success, we see translation not only across the United States but around the world.
Okay. I'm looking for more specificity.
Well, and I conceptually I agree. I think that this is a birthing of a new model that should translate across multiple subspecialties, and hopefully the patient population. But it would be very interesting and a real success if patients like Andrew had access to the care that they needed when they needed it and didn't arrive to the emergency room because of questions that were unanswered.
I've got a very specific thing.
You're getting a double lightning round?
You said patients don't like readmission. I'd actually like to challenge that. I don't think we have data on it, but patients feel safe in the hospital. And sometimes what drives patients to readmission is their fear. And we see that a lot in heart failure patients and others. And success in a navigator model would be that patients feel safe on the outside and are not readmitted for that reason.
Okay, you've just redeemed yourself. That's a good one. Judy's saying that's what she's saying too. So
Well put. I would just build on that. Those are all great visions. I think the other vision that we need to see come out of this is the fact that our list of must-have information about the patient is expanded and includes multiple aspects, includes a whole person focus.
Great. Andrew, you're welcome if you want.
I'm not really sure what I have to
Okay. So my goal is that we have a new way of thinking. That is, our success in the hospital is only measured by the degree to which patients are successful in their episode of care, not just in the first part. Hospitalization seen as the first part, not as a thing unto itself. We've decreased readmissions by 30%. And the innovations that we've identified are scalable and spreadable and are being adopted widely around the country as a first step towards truly seeing through the patient's eyes and the redevelopment of the healthcare system that's promoting value and understanding what we need to do from the patient's perspective. Yes, Kathleen. Lightning round bonus.
I know. I couldn't help myself because I get weepy actually by the energy and the excitement that this program is bringing to cardiovascular care. But to me, one of the largest contributions that we also have to make, in addition to good patient care and good patient outcomes and feeling safer, I appreciate your comments, Dr. Walsh, is the connection across these hospitals. Because we've watched, ACC has had many national initiatives go out. And one of the value components of that is by connecting what are those innovative packages that this one hospital, Project Access that you're talking about, well, what's the benefit of that helping Inova Fairfax Hospital? And that's partly of what I hope Navigator is going to be able, this program is going to be able to bring, is spreading that knowledge that Minnow talked about, but also sharing all of the great work and the ideas across.
Any other lightning round bonuses? Okay, we got somebody in the back room has got an aspiration for the program.
I'm Andre Williams with the Association of Black Cardiologists. I'm not a cardiologist. I'm the CEO of the organization. But I want to know, with the Patient Navigator, does it address racial differences in care?
Yeah, you know, the original Yale in this effort that really actually grew out of the community was intended to try to eliminate some of these disparities. The people who were falling through the gaps, they had no opportunity to access specialists. This particular program was an attempt to try to create a partnership with the physicians would say, we will make spots available for these patients. And Navigator would make sure we're making sure the right patients are getting to, that is, those who need a specialist, and would particularly try to find those individuals who would get the most out of the program. And Andrew's an example, but it went across the whole community, and certainly the idea of limiting disparities wherever they existed. Patients who were being marginalized by the current system could be brought in and saying, we can help, and that was the principal notion. I'm glad you brought it up because there are a lot of disparities. Just, oh, you want to please continue? Yeah, please. Quick follow-up.
Heart failure obviously is a recommended therapy for self-prescribed African Americans. So will it specifically a discharge address, you know, that issue?
So that therapy is best given in the outpatient setting, not in therapy, but we are always focused on evidence-based in the whole hospital home initiative, evidence-based therapy for all patients, and so that's already been a focus. But specifically at the time of discharge, it's not always given in the acute setting because of low blood pressure, et cetera. And as Harlan said, we're well aware of the issues with disparity, and in focusing on the hospitals that will be using the Navigator approach, we want to identify hospitals that have that need.
I'm Lisa Tate, Chief Executive with Women's Heart, the National Coalition for Women with Heart Disease. And I'm not going to let Andre get his question on the other underrepresented group. But just two-part question. One is, how has this program, or will it, address the issue of referral to cardiac rehab, referral and participation in, because as you know, women are less likely to get referred and less likely to participate in cardiac rehab. And secondly, how does it address psychosocial and issues of depression, for example?
So let me frame this, I think, in a better way. So Andrew's from a program that's being conducted at Yale that's using Navigators. we thought it would be a good idea for him to talk about what his experience is. This is a kickoff, not a launch, and I just want to make the distinction. It's a kickoff of the partnership. It's a beginning of a try to formulate what will this be, what will this platform be, what will this program be about. Part of it is going to be doing this needs assessment to say what are the targets of our attention that we ought to prioritize. So this is not a description of a program that's going to be spread among the hospitals yet. It's about saying we need to look broadly at best practice. We need to think differently about solutions. We need to understand deeply the problems, and we need to bring the talent and expertise that exists here and elsewhere to bear on what we will launch. But I think that the idea that this is still in formulation, so your comments are entirely germane to saying whatever we put together has got to pay attention to disparities, underserved communities, issues. When I was showing the post-hospital symptoms, more broadly than just the disease that brought them in, it's the illness that affects the individual and the context in which they live in trying to promote a way for them to get better.
Well, thank you, Harlan. I was going to make comments in addressing Andre. As part of the hospital selections, we'll be identifying some of the hospitals who have the greatest rates of readmissions, because in populations where there are disparities and people at risk, the rate of readmissions is actually significantly higher than, let's say, communities I represent in Los Angeles. So I think it is a challenge, and I think we're going to have, as part of this multi-stakeholder collaboration, working with all the various constituencies to reach out, see what works regionally, what works locally, because the solution may be different in each particular facility, as you can imagine. And I think part of the reason we've invited so many different constituents here this morning is to hear feedback as we evolve and develop this program down the road. You know, one of the quotations we had as we think about the program is, Benjamin Franklin once said, "Tell me and I forget, teach me and I may remember, involve me and I learn." And so the Navigator is really all about involvement. It's all about reaching out to the various constituencies that we work with a focus with the patient at the center of this universe. So everything evolves around this universe with the patient being at the center. And again, I want to just restate this issue, that this is a multi-stakeholder collaboration between a professional society and industry. And we think, as a first of its kind, I think this will be a paradigm and model for the future of other types of collaboration. We're already working with our sister societies. We're working with ABC. We're working with the American College of Physicians. We'll be working with the primary care physicians, because at the end of the day, it's all about the team. It's all about who delivers care, who's responsible for follow-up, who's responsible for communicating with the patient. And it's that crucial handoff period where most of these mistakes occur. And the most important time or at risk is this time of discharge, when, in fact, members of our cardiac care team, our nurse practitioners and so on, are probably pivotal. They are pivotal in delivering this content information. If we can continue this practice post-discharge, we're going to make a difference in patient care and outcomes. I'll give this back to Harlan.
Thank you. I think we appreciate all the good comments and discussion, and I think actually I'm going to transition back to Shal for final words. Is that what we were going to do, or am I doing final words? I am? Okay. Well, this has been well choreographed. Fumble at the end, but as I listen to all the comments, I think that it just reminds me of that we have a daunting task in front of us, and there are just many complexities. There have been a lot of advances. By the way, readmissions have dropped 1% in the last year for the first time that we've ever been able to document change. It does seem as if there's been improvements occurring, but the improvements are not uniformly distributed across the country, not uniformly distributed across all patient groups. And the speed of change, the speed of improvement, I think, should be too slow for us. We should be still discomforted by the fact that we're not moving better, faster, and that the gaps that we're identifying still exist in a broad-based way. Our challenge now, I think, in the next step is to try to bring together best practice, to understand what this platform will be, to identify some hospitals that are facing hard challenges but want to be at the leading edge of innovation. And they want to develop solutions that, while they may need to be customized and personalized for their own sites, have the possibility of being generalized and scalable so that people broadly can be benefited. And that we're continuing also to promote the broad brush cultural shift in the way in which we think about healthcare and value, and try to bring about that improvement in thinking about healthcare so that this effort on readmissions becomes the first in a step of a transition towards a truly much more patient-centered care delivery system, which is promoting better individual outcomes for each person who needs the healthcare system to work for them, not do things to them, but work for them. And I'm just so pleased to be with all of you on this journey. I want to acknowledge again AstraZeneca for their generosity and wisdom, and for the talent they will bring to this, and for the American College of Cardiology for creating the platform, Kevin Fitzpatrick for all of the work that he did in making this possible, and the team that has already put in hours and science and quality to make this possible. But I believe that we will look back on this day and say this was the beginning of a really remarkable effort together that changed the way in which care is delivered, and that was tangibly felt by patients like Andrew, who can feel more comfortable and confident in the care, and safer and better well taken care of by the healthcare system. And our encouragement for patients like you to participate actively and be engaged, so that you're not just passive but are part of the team in true partnership. That's going to be another part of this. But I want to thank everyone for attending today.